Welcome back to Infection Prevention, more than just gloves and gowns. I'm Jess, joined as always by my co-host Nicki.
Hey everyone. And today we're talking about Enhanced Barrier Precautions, EBP, which some people might read as evidence-based practice, but today EBP means Enhanced Barrier Precautions and how they're being implemented in nursing homes. It's an approach designed to reduce the spread of multi-drug resistant organisms, but putting it into practice comes with its own set of challenges.
So to help us unpack this, we're joined today by two experts who have been at the forefront of EBP research and implementation.
Yeah, first we have Dr. Mary Claire Roghmann, an infectious disease physician and epidemiologist at the University of Maryland School of Medicine. She's also a VA investigator, staff physician, and associate hospital epidemiologist for the VA Maryland healthcare system. Her research has played a major role in shaping EBP practices and helping facilities find real-world solutions for infection prevention.
And we're also joined by Stephanie Mayoryk, the president of Mayoryk Consulting Services, LLC. Stephanie has an extensive experience leading infection prevention programs in academic medical centers, community hospitals, and long-term care facilities. She's a registered nurse and infection preventionist and an expert in helping healthcare settings operationalize infection control strategies in a way that actually works for the frontline staff.
Oh, cool. She's been all over the medical system.
Mm-hmm.
And we also want to acknowledge Dr. Kara Jacobs-Slifka, who played a key role in this research, but unfortunately can't join us today due to federal policies that limit CDC experts from speaking directly to the press. While she's not here, her contributions to the study and to infection prevention as a whole are invaluable, and we are grateful for her work. So, Dr. Roghmann and Stephanie, welcome. Could you kick us off today with an overview of the study?
Absolutely. We're really happy to be here, and it is exciting that the work that we've done is going to be heard by all of your listeners. So until recently, there has not been a consistent approach to the use of personal protective equipment such as gowns and gloves for MDRO prevention in nursing homes. Since 2019, a form of enhanced barrier precautions has been used as a part of CDC and health department responses to outbreaks in nursing homes. But in June of 2022, the Healthcare Infection Control Practices Advisory Committee, or better known as HICPAC, finalized a white paper. I was a part of that group. And we developed some guidance based on expert opinion for the broader use of EBP in nursing homes. So that was a very difficult time for nursing homes and everybody because it was in the midst of the COVID-19 pandemic.
Right.
So there were a variety of things that happened over the next couple years that culminated in April of 2024, having Centers for Medicare and Medicaid Services, or CMS, include EBP as a part of their regulations. And so now EBP is indicated for specific residents, and we're going to get into that as a part of this particular project. So Stephanie,
Fantastic.
I'll turn it over to you from here.
Yeah, and our study was kind of rolled out in 3 phases. We did some pre-work. Our intervention included environmental assessments and kickoff planning among 4 nursing home short stay units in these nursing homes in Maryland. During that time, we assisted in equipment selection, gown selection, how to store PPE. We had an education phase where we did training and education with our frontline staff on what enhanced barrier precautions was and how to apply it. And then we had our intervention phase in which we provided frequent audit data and feedback to our frontline personnel on how they were executing EBP.
Great. So let's get started with some basic information. Let's talk a little bit about what enhanced barrier precautions are and why they were specifically developed for nursing homes.
I'll tackle that one. So enhanced barrier precautions are a way of using gowns and gloves for specific nursing home residents So we're going to get into the issue of which residents are placed on EBP as we go through this. But if a resident is placed on EBP, then we use gowns and gloves for what we call high contact care activities. And those are very specific activities that we've actually demonstrated that there is a high risk of contamination of healthcare workers' gowns and gloves during that specific care activity. So that in essence is what EBP is. And we can talk a little bit about what EBP isn't as we go through this.
Oh, I like that.
Yeah, and that leads me to my next question, because you talk about high contact care activities. And I think a lot of people might hear the word precautions and assume that that's full isolation. We kind of talked about gowns and gloves, but EBP is different, like you said. How does it compare to traditional contact precautions? What makes it a better fit for nursing home residents?
Well, contact precautions is the use of gowns and gloves for every entry and exit into the patient room. It requires dedicated supplies. It restricts resident mobility and participation in group activities, whereas enhanced barrier precautions is really for those high contact cares. And I do want to call out what those high contact cares are. It's when you're involved in a wound dressing change, some device care, bathing and toileting, dressing the resident, changing linens, and transferring the resident. So only during those instances are when gowns and gloves are required. Enhanced barrier precautions does not require a private room in most situations, unless dictated by your local health department. And there's no restriction in involvement in activities. So EBP can be viewed as a less restrictive measure than contact precautions in the control of multi-drug resistant organisms.
And so you mentioned in your high-level overview of the work that this primarily took place in those Maryland nursing homes. And can you just walk us through the approach for the research and what were some of the things that you were hoping to learn?
Well, I think we wanted to make sure we had this was a quality improvement project, right? How can we get EBP into these nursing homes, and how can we make EBP as effective as possible, have good uptick in compliance, as well as ensure we're removing some physical barriers to the enhanced barrier precaution implementation. Training and education was obviously a huge part of this, but also making sure that supplies and resources were on hand as needed to implement EBP effectively.
In your quality improvement project, you guys used the 4E model, right? The engagement, education, execution, and evaluation, which you kind of just talked a little bit about. So you used that to guide the process. Can you explain how that framework helped shape the implementation of EBP in these facilities?
Sure. I think it's a really easy process model to use. It really helped me personally organize the implementation. It comes from the model of translating research into practice. And these models can help a lot in basic project management and prevent us from kind of charging off out of the gate with some ideas or implementations that might not be supported by our leaders or current infrastructure and its resources. So we really want to make sure there's thoughtful pre-work. And the first E of the 4 E's is engagement. So it's really important to sit down with leadership and, start from scratch. What is EBP? Why is this important to your facility? Why is this important to your residents? And what tools and resources are you going to need to make this successful? I think it also gives us the opportunity to ask questions like, well, how do you view this project might fail? What are the barriers that you already know are in place? So as you go through the 4 E's, all the way down to execution, which is ensuring that every resident that deserves EBP, that it's being implemented appropriately for those residents. It's a great little model that's really easy to use and can be used both in acute care and long-term care. And not just for EBP, it can be used for multiple, infection prevention interventions, quality improvement projects.
I like it. I think
Yeah, I
that's
do too.
it looks really like a great way to frame how you're going to do a project, actually, because I think engagement is such a critical piece, and sometimes it's missed in that initial phase, because we want to get to the end point and solve whatever the problem is. But in this particular research, it involved a mix of observation and staff training and direct feedback from those frontline healthcare workers. What were some of the key takeaways from staff interviews, and how did their insights shape your findings?
I think in general, a lot of the staff really did understand that enhanced barrier precautions was a preventative measure for an effective in preventing multi-drug resistant organism transmission. There were a lot of great comments. One staff member mentioned that it's easier now because it protects us. They understood that it protected us and keeping the spread of infections from going to patient to patient. Others really appreciated the fact that enhanced barrier precautions didn't require gowns and gloves for every entry. Someone mentioned, I like the fact that I'm just dropping something off. I'm not going into the room. I'm not going to be in direct contact. I don't have to gown up every time, like would be the case with contact precautions.
Right.
But some did mention some barriers. Obviously, they do not love how hot gowns are. That was, I think, the primary number one reason why they didn't love EBP. And also, they felt like patient, resident, family member education was really important because they often felt the need to explain why they were gowned up when someone maybe wasn't on contact precautions or they weren't in outbreak mode. So that was really important for them to have some scripting related to what EBP is and have some preliminary education with our families and our residents on what EBP is.
And you touched on something earlier when you said, it should be easy for residents. And we've talked a little bit about staff buy-in and ongoing compliance, which, of course, implementing any infection prevention measure requires definitely both staff buy-in and ongoing compliance. So what were some of the biggest challenges that you encountered when you rolled out EBP in these nursing homes?
For me, it was the number of staff turnover, right? We started out with a list of who was going to be working over this training and education period, and the amount of agency personnel was pretty staggering. So making sure we were including our agency personnel in that education was really important. You'd think you'd be targeting someone that you hadn't hit yet, and they wouldn't be there to receive the education. Can be a challenge, but making sure we really had a prolonged plan to ensure everyone was covered and understood what EBP was important. Like all compliance activities, we're still humans. Human behavior happens. So when there's a miss in compliance, really trying to dig in with the staff on why there was a missed opportunity, at least during the training and education period of the study. Don't be afraid to ask why someone didn't wash their hands or didn't choose to gown up. It could be that they were busy and they just missed the sign on the door. But was there really a more important barrier to them not choosing to gown and glove? Were there not supplies available?
Right. It sounds like education was a big key. And you're hitting on something like when you need to ask why somebody was unable to complete the task at hand. So like you said, did they not see the sign? Is that not visible enough? Were the supplies not available? Did you offer any scripting?
We definitely had some education for our residents and family. Mary Claire, I don't know if you want to jump in on kind of how we tackled that throughout some of these projects.
So I want to say that Stephanie and our team were really creative about educational processes. And I think, as all of us know, having to do required training is one of the things that healthcare professionals dislike the most. And so creating those teachable moments, it was so critical for this program. We found that a brief moment of education at the point of care was much more effective than 5 minutes in a huddle, for example. And being able to kind of go back and forth with participants, or with our healthcare workers, was critical. when we saw a pattern that was emerging from questions, from barriers, we would create what's called a frequently asked question. And each week, we'd have a new frequently asked question and we would post it. It would be the size of a piece of paper and put it up on the boards. And we found this way of providing education to be more effective than a single kind of event. And I would say that that was one of the reasons why things worked well. I think the other part that really was absolutely critical was making the gowns and gloves available at the point of use. We went through a series of different, and it boils down to gowns, right? Because gloves get used a lot in nursing homes and in healthcare. And so everybody has the gloves readily available. But gowns are bulkier. And they need to be available when people are going to be going in to do this high contact care. And so we went through a variety of over-the-door solutions. And then not only thinking about what was going to be our mechanism of dispensing, but what was going to be our mechanism for making sure these got refilled. Yeah. And then we also had the issue of, all right, where are these gowns going to be disposed of? And how often does the trash need to be taken care of because of the fact that you have gowns now going into the waste paper baskets? Inevitably, we ended up using larger waste paper baskets or trash containers in the EBP rooms as one potential solution.
I think that's great. And I really like, that you were coming from a place of curiosity with the staff. I think that, we always say never assume negative intent, because I don't think anyone comes to work with the intention of, doing the wrong thing. So coming at it from that space of curiosity, I think also helps bring down some barriers. And then the FAQ, also fantastic, because we know that sometimes people ask questions, but or they have questions, but they don't want to be that person that's asking, they're not the one that wants to raise their hand. So I think that's also fantastic, because it's a way of educating, everyone with one key tool. You did mention that, comfort and practicality were something that came up through the frontline staff. Beyond the warmth of the gowns, what were some of the other issues around gowns and gloves, and what were some of the strategies that you used to improve comfort or maintaining of compliance with using those?
Well, as part of the study, we did let the facilities choose whether they wanted to continue with their current gown selection or use the ones that we could provide. And of course, coming from a university hospital, we had probably a more higher quality breathable gown. And that was more affordable to us than it was to our long-term care facilities. So 3 of the 4 facilities actually chose to go with our gown during this implementation period. Mary Claire, when we brought up in the pre-work as we were prepping for the study, the consideration of maybe even using aprons, which could be more comfortable. But she had talked to people in countries that use them more routinely, and they were not as enthusiastic and often felt unprotected. So we did not offer aprons as part of this study. And staff did really note that they do like the protection of gowns, but they just don't like how hot they were. So we haven't really cracked or had enough innovation in this space, even during the course of a pandemic, to get better gowns out to these long-term care.
I think there's your retirement plan right there.
Yeah, exactly.
Find that. Jess, we need to get on that.
I think as like future research considerations, is there an opportunity to use different types of coverings for specific high contact cares? I think also one of the things we promoted during the study that we think is feasible is, should we be promoting the bundling of high contact cares to limit the amount of gowns, the amount of time that healthcare workers actually have to be in gowns? Yeah. Many of the high contact cares that we focused on, do happen routinely during the AM and PM care process for residents. It's med passes, dropping off water, checking in, and maybe doing a partial assessment really don't require the use of the gown. So making sure that you're planning, what are you going to do when you go into the room? If you're going to get up, get somebody dressed, bathe them, toilet them. Most of those high contact cares are happening during that time, which can help limit the amount of time our healthcare providers actually need to be in gowns.
And just to throw
That's a
one
great
more
idea.
little thing into the mix is education at that point. Make sure if your people are properly doing their hand hygiene and changing their PPE if they're going from a dirty to a clean task. So even doing more education on bundling that care and the order in which to do that is that's another component that we would have to think about. But it's so much more efficient for residents and staff.
Exactly.
There's an issue of standardization. Like right now, different facilities might have different criteria for MDRO inclusion under EPP. So should there be a more standardized approach to determining which organisms warrant it, and how might that impact adoption?
So that's an absolutely critical decision that nursing homes need to make. So right now, per the CMS guidelines, EBP is indicated for residents with infection or colonization with a CDC targeted MDRO when contact precautions do not otherwise apply. So what's listed in there as targeted MDROs is pan-resistant organisms, carbapenemase producing carbapenem resistant gram negatives such as Pseudomonas and Candida auris. So those are the organisms that nursing homes must use EBP if there is infection or colonization. And the caveat there is their health department may say that they need to do something more than EBP. And then they go on to say that additional epidemiologically important MDROs may be included in EBP, such as MRSA, ESBLs, VRE, multi-drug resistant Pseudomonas aeruginosa. One of the things we discovered in doing this study is that if you use the criteria of, a history of colonization with an MDRO or a chronic wound or an indwelling device, 1 in 3 of your nursing home residents will be on EBP.
Mm-hmm.
Wow.
And the most common reason to be on EBP is this known history of colonization with an MDRO.
Mm-hmm.
So nursing homes do need to think hard on which MDROs they're going to have as an indication for EBP. There's the CDC targeted MDROs, but there's a place for local health departments to help give advice on what are the other epidemiologically important MDROs in their region. And there's a place for nursing homes to use their risk assessment to determine those other organisms.
And speaking of like the health department working with some of the facilities and kind of giving them advice, showing them how to take care of these patients, it's critical for the flow of the entire healthcare system. So you can cause a real clog in the healthcare system if these nursing homes do not know how to effectively manage patients with targeted MDROs. Because what happens is the patients with those targeted MDROs can get stuck at the end of the acute care process and not have a lot of options. So your research is really helping the entire flow of the healthcare system. So thanks, guys.
And I do think that's one of the reasons why EBP was rolled out at the time it was, because people needed a type of transmission, and I'm going to use this term, transmission-based isolation precautions. They needed a type of transmission-based isolation precautions that could work within nursing homes.
Mm-hmm.
We hope one day that EBP will be listed in the new transmission-based isolation precautions, which have not yet been released. But they are in the draft.
Yes, they are. We've been talking a lot about that. So I think Nicki sort of touched on this earlier, but and I think Stephaie as well, around the, you're trying to train and you have a lot of, changing of the staff. So what were some of the ways that you found would be helpful to maintain a strong EBP program when you have this flux in resources and staffing?
It definitely needs to be included in your general orientation and your agency orientation education when you have new people coming in. We did actually find out who the agencies were that were feeding these organisms, and the IPs helped send some of the basic FAQs and training information out to them as we were leaving, as the study was wrapping up, to make sure that they understood what EBP was and what staff that were entering these facilities were going to be expected to perform. I was actually surprised at the amount of acute care staff that were picking up shifts in the long-term care environment. And I think it's important to reflect that enhanced barrier precautions isn't well known to our acute care colleagues, right? And there's really an opportunity, as you mentioned, for throughput to discuss and collaborate with your feeder facilities so that they understand what EBP is and maybe can even help facilitate.
Absolutely, yeah.
Who's going to be on EBP.
Yeah.
So including your admit liaisons, things like that, and that education, and trying to reach some staff that aren't typical long-term care nurses and nursing assistants.
Let's talk about indwelling devices and such, and how EBP is used for those particular patients in their care.
So, as I mentioned, EBP is now indicated for residents who have infection or colonization with a CDC-targeted MDRO, or a wound or indwelling medical device, even if the resident is not known to be infected or colonized with an MDRO. Now, it goes on to say, and it's actually designated in the CMS document, that wounds include chronic wounds. So these are not shorter lasting wounds such as skin breaks or skin tears that have a Band-Aid on or similar dressing. We're talking about things like pressure ulcers, okay, diabetic foot ulcers, or a venous stasis ulcer, okay, an actual chronic wound. Whereas indwelling medical devices include things like central lines, urinary catheters, which is the number one indwelling medical device that we saw in our study, and I think in others. The occasional feeding tube, and if you're on a chronic ventilator unit, a tracheostomy tube. Peripherally inserted IV lines, just a simple IV, would not be considered an indwelling medical device for the purpose of an EBP. And it's really important to define those things. We had all sorts of questions. So, for example, I remember somebody saying, is my continuous glucose monitor that my resident is on, is that considered an indwelling medical device? And the answer is no. The CDC has some great frequently asked questions around these particular areas, and you can clarify. I want to highlight, too, that if you can get a medical device out, then that resident does not need to be on EBP any longer. And so this is yet another reason why the discontinuation of indwelling medical devices is a good thing.
Yeah. Yes, yeah. More focus on getting those indwelling devices out. And I got another question too. How does this affect patient or resident movement through the facilities and their presence in common areas?
It doesn't at all. They are free. If they are on enhanced barrier precautions, they are free to participate in group activities, ambulate, do all of those things, go on family visits. They are not on full-blown contact precautions. So there is no restriction as far as them being able to leave their rooms or participate in activities throughout the facility. Go to common dining areas. All of those good things are on the table whenever it's on EBP.
So I think, go ahead.
I was going to say, and that's critically important because, what people in acute care don't often appreciate is that part of the therapeutic benefit of a long-term care setting are all of those activities. They need to ambulate. Okay, they need to improve their mobility. They need to get out and socialize and, play cards and any other
Absolutely.
activity that is
Yeah.
within those facilities. And when this was really, when I first started working in this area, it actually came. So back in, and this is going to date me, back in 1997, I became a hospital epidemiologist in our VA healthcare system. And the first task I was given, that I gave myself working with the team, was to update our transmission-based isolation precautions. One of the things I noticed or realized is that I was taking care of an entire healthcare system. Within my system, I had about 120 acute care beds, but I had 500 long-term care beds,
Mm-hmm.
and then another series of several hundred mental health beds. And that transmission-based precautions, as we're currently written, didn't work outside of acute care. And that is actually what started me off in helping to develop enhanced barrier precautions, was trying to develop a form of transmission-based isolation precautions that can work within a non-acute care setting, such as a nursing home.
Let me pose this question because I think this was a problem with a lot of the throughput, especially with Candida auris. So there wasn't a whole lot of research out on Candida auris. It was a new superbug that scared the bejesus out of everybody. So a lot of nursing homes and post-acute facilities were not accepting people who had Candida auris. So how do we manage that?
Well, really, the involvement of your local health department is going to be really important to manage Candida auris. Though we say with enhanced barrier precautions that private rooms aren't required, some states are suggesting and recommending that private rooms are part of their Candida auris recommendations, which can affect throughput to this day.
Yeah, because I think a lot of the fear was, like you said, Dr. Roghmann, you have to be able to play cards in the common area. You can't be socially isolated. But I think a lot of the facilities were scared to take somebody who was colonized with Candida auris and put them in their facility.
So I will throw in a plug for research that's currently being done at the University of Maryland as a part of our CDC Prevention Epicenter. We are actually doing gown and glove contamination studies with inpatients who are Candida auris colonized to help determine which are the types of high care activities that lead to gown or glove contamination. And when I talk about gown and glove contamination, we're culturing, a healthcare professional's gown as a proxy for whether their clothing or their scrubs would become contaminated if they didn't have the gown on. And then we're culturing the gloves as a proxy for the fact that their hands would have become contaminated.
Okay, we'll make sure that they publish an AGIC so we can interview them.
We cannot. The organism Candida auris cannot be brought into conversation without Nicki having something to say about it.
No, it cannot. You are correct.
I was like, as soon as Dr. Roghmann said Candida auris, I was like, well, here we go.
You got about 50 minutes you have to edit out, Blake. Sorry, just kidding.
No, this is amazing. So, you mentioned earlier, Dr. Roghmann, that you were going to maybe tell us a little bit about what EBP is not.
I think we've touched a lot on what EBP is not. All right. And I think this was a really important part of our education. Okay. EBP is not contact precautions. So EBP does not require a private room. Private rooms are uncommon in nursing homes. Mm-hmm. Hopefully that will change one day, but they are not. And so that is actually one of the issues when it comes to, transfer to nursing homes, if a private room is needed. EBP does not require room restriction for regular everyday activities. We want these residents to be doing the activities that will help them, rehabilitate. Or if it's their home, we want them doing the activities that they know are, that bring them quality of life. Okay. We do not want staff not interacting with these residents. So if you go in and you're like, for example, going to set up a tray and help somebody eat, you don't need gowns and gloves on. It's not a high contact care activity. So those are the things, those are sort of the messages that need to get across.
Yeah.
We often were asked, by family and friends, do I need to wear a gown and gloves? I don't know, Stephanie, if you want to tackle that one.
Yeah, I mean, we did not require families to gown and glove as part of this EBP protocol. I think we focused more on the fact that with EBP, standard precautions is still in effect, right? EBP does not replace standard precautions.
Right.
So anytime hand hygiene is required, you're going to have contact, hand hygiene should be performed. Anytime you're touching an environmental surface that could be contaminated, hand hygiene is required. The appropriate use of gloves is still a component of standard precautions. If you're going in to do some trach care, and enhanced barrier precautions is part of that. Don't forget your eye protection. So EBP is great. It's kind of that middle of the road prevention measure, but it doesn't replace standard precautions, and it's not quite full throttle as contact precautions.
I think that's very important to highlight because I think sometimes we get so focused on transmission-based precautions, we forget standard precautions. And it's...
Yep.
And the same can happen with EBP, right? I'm doing all this. I can forget hand hygiene. I can forget environmental disinfection. All those things are still important. Eye protection, prevention of splashing and spraying. All of those things remain important.
Yeah. And sorry for all the other questions too. It's so hard for me, and I'm sure it's with Jess too, like coming from the acute care side, trying to, which is what you hit on, Dr. Roghmann. Your whole point was to try and adapt this for post-acute care. So let me ask another question. We'll kind of switch gears a little bit about the environmental impact of increased PPE use. So if facilities are thinking about that environmental impact, how can nursing homes balance infection prevention with sustainability concerns, particularly when it comes to PPE waste? Because I'd love to think we could get some federal leadership to give us some care about long-term sustainability, but I don't know if recent public health funding trends are any indication that we'll get any of that. But I don't know if if you have any tips about the environmental impact. Can we take this? Yeah, go ahead.
Oh, I was going to say, I really appreciate this question. I care very deeply about the environment, and I hope one day that we're going to move away from disposable products such as gowns. I need our colleagues in engineering and human factors to really be thinking about how we can do things differently. For now, this is what we have. Okay. What can we do to help reduce gown use? Well, we can educate well about what EBP is, and we've hit on all of these issues. We need to think carefully about which residents should be placed on EBP, because placing a resident on EBP will drive up the gown use. Gloves are going to be used regardless. Okay, I'll just put that right out there.
Yeah.
So, really considering which MDROs, which history of MDRO colonization, which ones are you going to use for EBP? Carefully defining those chronic wounds and getting those devices out can make a huge difference to the number of residents in your facility who are on EBP.
That's right. Getting those devices out has an environmental impact.
It does in many ways. And then, we brought up the issue of bundling care activities. Now, I'd like to say that we invented bundling care activities, but we didn't, right? healthcare staff have been bundling care activities for efficiency for decades. And particularly in nursing homes, there are key activities that go together. Those in the morning to get somebody up and about, and those at the end of the day. And getting all the high contact care activities done at a single setting is very useful and can reduce your gown use. Those are what we have now. And I think we need to continue to do research on how to develop better barrier precautions. But also, one day, perhaps we can figure out a way of making it so that people do not remain colonized with these resistant organisms.
It's hard to care about infection prevention and the environment. Well, guys, this has been a very insightful conversation, and there is clearly a lot to consider when it comes to making EBP work in real-world settings.
And so before we wrap up today, do you want to leave our listeners with some takeaways, maybe some of the things that went well and some of the pitfalls to avoid?
Definitely appreciate the facilities that we worked with. We were very lucky to have very engaged infection preventionists at the local level that really wanted to see this project succeed and recognize the impact that enhanced barrier precautions could have on their residents in terms of outbreak prevention, MDRO transmission. So that was really helpful, and we really appreciated their efforts. I think, sustainability is always going to be hard, right? We can roll out these interventions, and when we pack up our study and go home, what's left out there as far as being able to keep this momentum going. And I do feel strongly that enhanced barrier precautions can and should be part of every infection prevention annual plan, surveillance plan, QAPI committee from this point forward. Process measure monitoring on these high contact cares should be happening. Direct observation should be happening. It's not financially cost prohibitive, but it's time intensive. We do know that. So just trying to build EBP measures into your current plans can go a long way in helping to assure sustainability.
Yeah, it's a lot to take in. I appreciate both of you all so much for joining us today.
And thanks to our listeners. If you found this episode helpful, subscribe and share with your colleagues. We want to get the word out. We'll see you next time on Infection Prevention, and it's more than just gowns and gloves.
Yeah. Well, thank you guys.
Thanks for having us.
Yeah. It is funny. It's more than just gowns and gloves. I don't know. Are you mostly just gowns and gloves?
Is it really more than just gowns and gloves? Yeah. Maybe it is just gowns and gloves.
That's a wrap, Nicki.
That's a wrap.
Thank you for joining us today. We are Nicki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Althen and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.